Hi, good
Hello,
evening.
ma'am. A very good afternoon, a very good evening. And Dear audience, welcome to a brand new session on a special discussion on recurrent pregnancy loss. Now, as you know, RPL defined as a failure of at least two consecutive pregnancies before 20 to 24 weeks of gestation affects around 2.5% of women globally. It is a multifactorial condition that can be caused by genetic, anatomic, endocrine, immunological, or environmental factors. Up to even 50% of the cases of RPL lack a clear etiology. So please join us in this session with Dr. Manju Jilla. Hello, ma'am. Very good afternoon.
Hi.
Very good evening.
Yeah,
Welcome to the
hi.
session. I'll speak a little about the speaker here. Dr. Jilla is over 25 years of experience in assisted reproductive technology and has performed over 10,000 laparoscopic surgeries in her career. Her areas of expertise include transvaginal sonography, gynecological endoscopic surgery, color Doppler ultrasound, etc. She's also taken keen interest in IVF and ICSI and is an expert in complicated procedures like myometromies and laparoscopic endosuturing. She's currently the IVF specialist in Jilla IVF Center in Mumbai. Over to you, ma'am. Always a
Hi.
pleasure to have you with us
Hi.
here.
Yeah, we all gynecologists in our day-to-day practice see recurrent pregnancy loss patients, and sometimes it is very frustrating if we are unable to find the etiology. Broadly, we can divide pregnancy losses as those happening in the first trimester and those in the second trimester. The second trimester pregnancy losses could be because of cervical incompetence or uterine infections, like because of premature rupture of membranes, or because of certain uterine anomalies. But the more frustrating ones are the first trimester abortions, most of which in the previous era we thought were genetic. But now we realize that a huge chunk of these are also because of immune dysregulation in the mother. So let us look at these causes and how we can manage these recurrent pregnancy losses in short. I'm going to be very short and I would encourage more and more questions because this is a multifactorial problem and each one of us must have faced different problems with our patients, and it would be excellent to have a discussion on this topic. So just as Madam just said that two consecutive abortions with in less than 23 weeks of gestation with the same partner, this is what ASRM says, incidence being 2% of recurrent spontaneous abortions, 50% of the time the cause is unknown. And of these unknown causes, they say that 80% of these unexplained recurrent pregnancy losses are because of immune factors. Embryonic chromosomal abnormalities are also common cause of RSA. However, we rarely find a problem in the mother or the father's karyotype or even the genome. So it could be that when the embryo is being produced or during meiosis and mitosis, the alterations in the genes or the defects in the chromosomes could have occurred de novo. So let's look at the anatomical factors. They account for around 8 to 12% of recurrent spontaneous abortions. We have different anomalies: unicornuate uterus, bicornuate uterus, arcuate, septate. These are amongst the commonest. Acquired anomalies include Asherman syndrome. We say cervical incompetence. Congenital is very rare, but commonly it is acquired, and fibroids and even adenomyosis. Septate uterus is the commonest anomaly causing recurrent spontaneous abortions. The best way to treat a septate uterus is by hysteroscopic resection of the septum. We must look at complications like bleeding, perforation, and formation of intrauterine adhesions and uterine rupture at full term if we have cut the septum too deep into the myometrium. Pregnancy rates after septum resection are as high as 63% and live birth rate as high as 50%. Very often, septate uteri are associated with cervical incompetence, and one should look for these when these patients of septum resection have conceived. Intrauterine adhesions, also called as Ashermans, occurs when the basal layer of endometrium is damaged by infections, surgery, leading to a complete or partial obliteration of cavity. If it's a complete obliteration, pregnancy would not occur, but sometimes in partial obliteration, we do get pregnancies which land in spontaneous abortions. and they continue to be in spontaneous abortion unless we clear these obliterated areas of adhesions. Histoscopic adhesolysis is the treatment of choice. 75% of the patients will have a relapse of adhesions unless we take some care, like putting in a catheter or using anti-adhesion barriers or estrogens soon after the resection of these adhesions. A thin endometrium may first of all avoid implantation. But if at all implantation occurs, chances of spontaneous abortions are high in these patients. So endometrium less than 7 millimeters on the day of HCG can cause recurrent spontaneous abortions. Subendometrial PRP, GCSF, and stem cell infusion into the spiral arteries will restore the endometrium. GCSF is a stimulant of the endometrial stem cells, and it also has an immune regulatory effect on recurrent spontaneous abortions. Bone marrow derived stem cells in the uterine artery can treat severe Asherman syndrome, and women who have had Asherman syndrome and no menstruation at all have been treated very successfully with stem cells. Subendometrial PRP. Actually, PRP contains a lot of cytokines and growth factors, and subendometrial injection of PRP through histoscopy improves endometrial thickness, and that can be a treatment for spontaneous abortions caused by a thin endometrium. Cervical incompetence. It manifests, as we all know, with painless dilatation of cervix and delivery of the fetus in the mid and third trimester. Transvaginal cervical circlage should be advised to all patients of cervical incompetence. We have McDonald's and Shirodkar stitch, and actually Shirodkar stitch is much more reliable and gives better results than the McDonald's stitch. It can be done vaginally, and we can remove the stitch when the patient is at term. Laparoscopic cervical stitch is reserved for those patients who fail to go to term with vaginal cervical stitch, either Shirodkar's or McDonald's stitch. Whenever there is a cervical dilatation in an unexpectedly, this patient comes with a dilated cervix. A stitch at that time, like a worm stitch, really is not very successful, but may just help you to push the labor a little later till you give magnesium sulfate and betamethasone for the maturity of the lungs and brain. Hence, antenatal checkup for cervical incompetence in all patients is really important, and giving a prophylactic stitch before the cervix opens is what will help these patients the most. And taking a good history about the previous pregnancy loss will help us to identify cervical incompetence much early than late. Well, genetic factors is embryonic aneuploidy increases with maternal age. We know that analysis of miscarriage reveals that 55% of the early miscarriages are due to chromosomal abnormalities, of which 40% are due to aneuploidy, that is a single chromosome abnormality. 7.5% are due to polyploidy, that is multiples of 23. Around 3.6% are due to partial aneuploidy and microdeletion, and uniparental disomy are seen in a small percentage of embryonic loss of the fetus. Non-invasive, previously there was a lot of debate about using pre-implantation genetic diagnosis for women who have chromosomal abnormalities in their abortuses. Non-invasive PGTA can improve pregnancy rates in women with recurrent spontaneous abortions due to aneuploidy. The only harm that PGT was doing was the biopsy part of it, the freezing, thawing, and the biopsy. Of course, freezing, thawing techniques have now become extremely good, and frozen pregnancy embryo rates are as good as, or maybe even better than, fresh pregnancy rates. But the biopsy part, which was very tough, now has been replaced by the spent culture media analysis of the chromosomes, which is now a very promising field for women who suffer from pregnancy losses due to aneuploidy, especially advanced maternal age. Now, male factors, severe sperm deformities, sperm DNA fragmentation or DNA damage, and males with chromosomal abnormalities they have the direct causes of recurrent spontaneous abortions in women. The most common cause of DNA fragmentation seen in the population is a varicocele. And varicosilectomy really gives very good results. Almost 30 to 40% of the patients post varicosilectomy deliver a healthy child. Besides the ROS, the DNA fragmentation in the sperms can occur, which occurs mostly in the epididymis, is caused because of smoking, bad dietary habits, stress. So all this increases the ROS in the sperms. The sperms sit in the epididymis for 4 to 5 days, and they're exposed to the serum, the paternal serum at this time, and all the toxic material from the serum damages the sperm membrane, which is nothing but a lipoprotein membrane with a pack of chromosomes inside it, and leads to DNA damage. Use of antioxidants, then good lifestyle modification, stopping of smoking, correction of varicocele, and any toxic factor in the body, like if she is on certain drugs or if they are on chemotherapeutic agents, they all can damage the sperms. Now, infections in the genital tract in the mother are a common cause of recurrent spontaneous pregnancy losses. The common organisms are anaerobes. They can hardly be cultured. Diagnosis of these organisms really becomes difficult. These organisms actually live in the endometrial cells. They'll grow and divide in the endometrial cells. Like these organisms are uroplasma, mycoplasma, chlamydia, and in our country, even tuberculosis. And they are closely related to recurrent spontaneous abortions. They interfere with the regulatory mechanisms of the maternal immune systems. There are now DNA tests in order to find out about these presence of these organisms inside the uterine endometrium. Because these organisms cannot be easily cultured, swabs taken from the endometrium can be analyzed by multiplex PCR for the DNA sequences of these organisms, and we can be sure whether any of these organisms are present in the uterine cavity and are causing recurrent pregnancy losses. If so, the drugs of choice for these organisms is azithromycin, which is the first line treatment, quinolones, which are the second line treatment, but a combination of azithromycin and doxycycline being given for 21 days is more effective, while azithromycin is given just for 3 days. Whenever we are giving long-term antibiotics, it is always better to maintain the genital microbiome by addition of lactobacilli and B complex, which will restore the normal flora. Now let us look at the endocrine factors. Hyperprolactinemia is very common in women who suffer from recurrent pregnancy losses. We know that prolactin suppresses the hypothalamo-pituitary ovarian axis, leading to reduced FSH-LH and therefore reduced E2 and progesterone from the ovary. Many times these women remain infertile, but if at all they conceive due to low levels of hormones, it leads to an abortion. Dopamine agonists are the treatment of choice. Previously, we had bromocriptine, but it was not really well tolerated by the patients. Now we have cabergoline, which is well tolerated and gives excellent results. Patients do conceive, but once they conceive, cabergoline should be stopped because of its teratogenicity. Now, thyroid is a very important hormone as far as reproduction is concerned. And in the recent years, we all know that this is the production of leukemia inhibitory factor in the endometrial, stomal, and the epithelial cells. Hyper or hypothyroidism both can lead to abortions. Hyperthyroidism is a systemic metabolic disorder causing placental dysfunction and abortion. Antithyroid drugs, majority of them are teratogenic. But if we discover hyperthyroidism during pregnancy, PTU and methimazole can be given. If hyperthyroid is diagnosed before the patient becomes pregnant, when she comes with a history of recurrent abortions, it is better to give her radioactive iodine, destroy her thyroid, and wait for the wash-off period of this radioactive iodine, and then proceed for a pregnancy, adding thyroid, because now we have made her completely hypothyroid. We will have to add L-droxin and then let her have a pregnancy, which is the safest way of treating women with hyperthyroidism. Hypothyroidism, it mainly is caused by autoantibodies, anti-TPO and anti-thyroglobulin antibodies. Elevated TSH causes luteal phase defect and immune imbalance. As I said, that the endometrial epithelial cells and the stromal cells have got thyroid and TSH receptors, and any defect in or any deficiency in the thyroid hormone leads to decreased production of LIF and LIF receptors and causes an immune imbalance and leads to an abortion. So hypothyroidism should be actively treated until TSH level reach 2.5. PCO is associated with endocrine problems. We all know obesity, insulin resistance is a known thing in polycystic ovarian women. Recurrent spontaneous abortions in PCOS should be managed first by lifestyle, that is weight reduction, diet, and exercise. Letrozole is the first line for ovulation induction in PCOS patient because it does not affect the endometrium. Oral metformin also improves pregnancy rates and reduces abortion rate in patients with PCOS, which should be added with B12 because metformin causes B12 deficiency. And close observation for gestational diabetes during pregnancy is essential when PCOS is conceived, and especially when previously clomiphene was used, multiple pregnancies were higher. Thanks to letrozole, that we do not get such a high incidence of multiple pregnancies in PCOS. Now we'll focus on one of the burning topic or one of the most disturbing topics to all the gynecologists. That is, you see a pregnancy, you see the heartbeat, and you suddenly see it stopping. And really the cause is not known. We send the embryo for a microarray and everything comes normal. There is no immunology, there is no genetic defect in that embryo. Then what is the cause of this first trimester or early pregnancy loss? Most of that is because of immune factors. Now, immunity can be divided into two types, autoimmune and alloimmune. Autoimmune is where when the placental, that is the fetal tissue, the placental trophoblasts enter the maternal circulation and the mother produces antibodies which react with her own cells, like they react with the vascular endothelium, producing antiphospholipid antibody syndrome. We call this antiphospholipid antibody syndrome because every cell in the body is made up of phospholipid membrane, and antibodies for the cell membranes which are lining the blood vessels are called as the antiphospholipid antibodies. This reaction causes inflammation, and this inflammation causes clotting at various organs, and maximum clotting occurs at the placental interface, which cuts off the blood supply to the fetus, leading to an abortion. So that is autoimmune. Besides antiphospholipid antibody, which is the commonest, and not just anticardiolipin antibody or lupus anticoagulant antibody or anti-beta-2 glycoprotein antibody, but there are so many different antiphospholipid antibodies which we hardly can diagnose in our day-to-day practice. Anti-nuclear antibodies and anti-TPO are other autoimmune causes of recurrent spontaneous abortions. Now, how do we treat that? We will see in the next slide. But alloimmune, the second part, other than autoimmune, the second type of immune rejection of the fetus is alloimmune, where at the level of the decidua, the maternal decidua fails to tolerate the fetus, which is a foreign tissue. It just rejects it, and therefore the embryo is lost, or the fetus is lost, and we see recurrent spontaneous abortions. All of us are genetically different. All of us are immunologically different. And that is why some women are extremely fertile. The moment they get married or they have their first baby is born very early, because there is no immune rejection in their body. Implantation is very high. Pregnancy progresses very well. But in some women, because of the type of immunity that they have, they do not conceive fast, or if they conceive, they land into abortions. growth retardation, pregnancy-induced hypertension, all this because of the inheritance or the type of immune inheritance they have got. So let us look at antiphospholipid antibody syndrome. It is a non-inflammatory autoimmune disease causing production of large amount of antiphospholipid antibodies during pregnancy. At present, low molecular weight heparin and ASA are the chief symptomatic treatments to prevent placental thrombosis and abortions. I'm saying every word here counts, symptomatic treatment. The correct treatment for APL syndrome would be to remove the baby. But we do not want that to happen till the baby is full term, because we want to remove the source, that is the trophoblasts which are entering the maternal circulation. So in order to allow the baby to grow and not let the thrombi grow, the inflammation in the vascular bed, we use low molecular weight heparin and ASA. Low molecular weight heparin is more effective than ASA alone. To reduce immune inflammation, prednisolone and hydroxychloroquine given early in pregnancy show a better curative rates of RSA and better pregnancy outcomes. These are some research papers that are claiming these findings. The British Society of Immunology considers low molecular weight heparin, hydroxychloroquine, ASA and prednisolone safe in pregnancy, and so they can be used in women with APL syndrome. Now let us look at alloimmune RSA. Alloimmune recurrent spontaneous abortion is still at its research stage. It can be that there is over-immunity or hyper-immunity, or it can be that there is lesser immunity. Both of them will reject the embryo. So the decidua is infiltrated with immune cells like the natural killer cells, the dendritic cells, macrophages, and lymphocytes. These cells may allow implantation of the trophoblast or reject it by causing recurrent spontaneous abortions. Women with RSA who have a hyperimmune state have a higher percentage of CD56 cells in their blood as well as in their decidua around the time of implantation. These CD56 cells in the decidua, these are the natural killer cells or the innate lymphocytes, which have got certain killer receptors on their surface. If they are the ones which produce bad cytokines or inflammatory cytokines, probably the pregnancy will be rejected. So if the bad cytokines are the TNF alpha, IL-6, IL-13, these are the bad cytokines. And there are certain CD56 cells inherited with good receptors on them. They will produce the good type of cytokines which will allow the trophoplasts to grow and which will allow angiogenesis and implantation to happen. And these cytokines are IL-4, then the transforming growth factor beta. So any dysregulation in the type of cytokines produced by the CD56 cells in around the spiral arterioles would have an effect on the continuation of the pregnancy. So we call this as immune dysregulation and inflammation leading to spontaneous abortions. Reduction in the immune response may also lead to RSA. So if you have very low levels of CD56 levels, probably the changes required for implantation, like the IL-4 and the transforming growth factor beta, may not be enough for the implantation to occur, and the pregnancy will be rejected before it implants or even after it implants. Hence, optimum evaluation of immune defects and its treatment is a cornerstone of managing alloimmune recurrent spontaneous abortions. So we see that the blastocyst it's not a completely maternal tissue. It has got foreign proteins, and the syncytial trophoblasts have got HLA class 1 antigens, that is HLA-C and G. So these HLA-C, if they are inherited from the paternal inheritance, we have different two HLA molecules, HLA-C1 and HLA-C2. On the 80th carbon atom, if a different amino acid is there, in C2 it is glycine, and in C1 I think it's arginine. So the C2 types are more toxic, and if they interact with the killer immunoglobulin receptor of the natural killer cell, then
probably it doesn't allow a good implantation and leads to either growth retardation, inadequate penetration of the spiral arteries, PIH, and pregnancy losses, which we will just see later what type of killer receptors are present on the killer cells. So it is now seen that on our chromosome number 19, women inherit their killer immunoglobulin-like receptor genes. And these genes can be inhibitory or they can be secretory or stimulatory. So the inhibitory KER gene, if from the father and the mother, she has inherited the A type of KER gene, killer immunoglobulin receptor gene, then she is called as KER AA type. She has got KER AA receptors on her killer cells. And in the blastocyst, the syncytotropoblasts, they inherit HLA-C2 molecule from the father. This combination of KER AA and HLA-C2 may either inhibit implantation or cause IUGR or PIH. So inhibitory KER genotype is more common in women with implantation failure, spontaneous abortions, IUGR, and PIH. So KER genes, KER receptors are present on KER receptors are present only on the uterine natural killer cells and not on any other lymphocyte. They accumulate in large number around the extravillous trophoblast cells, and they actually form connections with the HLA-C2 on the tropoblasts. And this connection will lead to production of good cytokines or bad cytokines. So if it is a KER AA HLA-C2 combination, we would not get the good cytokines, and therefore we would get these problems like abortions, IUGR, and PIH. So in women in whom we are getting recurrent spontaneous abortions, we can look for their KER gene pattern and we can look at their paternal HLA-C. So in short, this is all still at research phase. We have not got this into our day-to-day practice, but patients still want answers to the problems that they are facing. Lot of immunological tests are coming forward, looking at the blood CD56 levels, looking at the cytokines in the blood, the TNF alpha level, the ratio of IL-4 and TNF alpha. Apart from that, the ratio of T regulatory and the Th17 cells. So a lot of these are coming forward. Besides that, certain small single gene disorders which may have an effect on the growth or the invasion of the placenta, like defects in the matrix metalloproteinase gene, which is important for the invasion of the cytotrophoblast, also can lead to spontaneous abortions. So we have a battery of tests of, those genes which get upregulated around the time of implantation. And there are a group of patients who have certain polymorphisms in these genes, and therefore they land into recurrent spontaneous abortions. Even like genes of the estrogen receptor or the progesterone receptor, if they are defective, then also a woman would land into spontaneous abortions. And so a huge battery of tests is required to pinpoint the reason of spontaneous abortions in recurrent abortions in women. And we genuinely need this as early as possible to diagnose these problems. So live birth rate, we have used cyclosporine, which is an immunosuppressant. And in low doses, it is found that this can induce immune tolerance and enhance trophoblast invasion. The live birth rate was with cyclosporine in one of the papers was found to be 76.9%. It was added before and after pregnancy. Cyclosporine A concentration was maintained up to 80 to 150 nanogram per ml during treatment. Cyclosporine is useful in refractory, unexplained, recurrent spontaneous abortions where progesterone, aspirin, prednisolone, low molecular weight heparin, lymphocyte immunotherapy, and IVIG have failed. Now, a lot of work has been done on lymphocyte immunotherapy way back in the 90s and early 2000s. I think in the USA it was introduced, but it got banned in USA. But there are many countries like Japan, Germany, who have been using lymphocyte immunotherapy in patients who have recurrent pregnancy losses of the immune types. So pregnancy is a semi-allograft, blocking antibodies for paternal antigens, then the protect embryo from immune. It is the blocking antibodies of paternal antigens protect embryo from immune rejection. Lymphocyte immunotherapy is an active immunotherapy that induces blocking antibodies after giving paternal lymphocytes intradermally to the mother. Pregnancy rate and live birth rate was significantly higher with LIT, even at lower doses of 100 into 10 raised to 6 lymphocytes per DL. 3 to 4 sittings of LIT around 3 to 4 weeks apart would usually produce blocking antibodies, and this mixed lymphocyte reacting blocking antibodies can easily be detected in the mother's blood, and once they are detected, the patient is allowed to conceive by 6 weeks. Now, TNF alpha, we know that this is a bad cytokine. It causes inflammation at the decidua. The expression of TNF alpha in the blood and decidua of patients with recurrent spontaneous abortions unexplained was found to be very high, significantly higher. So in these patients, TNF alpha inhibitors can increase live birth rate compared to placebo. This is Endocrine, ENAS, I'm sorry. And the safety and efficiency of TNF alpha inhibitors needs to be further confirmed with more studies. IVIG. Since 90s, IVIG has been used for recurrent spontaneous abortions. A lot of controversies are seen, but a lot of papers, and I personally also have got experience that IVIG is doing a great job in recurrent spontaneous abortion patients. This strategy is useful in women who have a very high CD56 count. People have used, because IVIG is expensive, we have used intralipid supplementation with similar effects at a lower cost. So in short, whenever the immune response is excessive, what we do is elevated NK cell or NK cell toxicity, we can use IVIG or intralipids. Elevated Th1, Th2 immunity, we can use tacrolimus, TNF alpha, or prednisolone. For ANA antibodies or anti-nuclear antibodies and antiphospholipid antibodies, hydroxychloroquine and dexamethasone, low molecular weight heparin and ASA for APL syndrome. And where the immunity is low, we can use immunotrophic agents like whenever there is decrease in the T regulatory cells, GCSF can be given. And whenever there is a decrease in endometrial CD56 NK cells or IL-15 upon FN14 gene expression ratio, then we can do a DNC and endometrial scratching that improves the immunity in the local immunity in the endometrium. Thank you.
Thank you so much, ma'am, for the wonderful lecture. I think you explained it really well regarding all the therapies that you could talk about. We have a couple of questions from the audience. We'll take those.
Yeah. Let's see why my battery was running low. I don't understand.
Okay. Ma'am, you can stop sharing the screen.
Yeah, I'll stop.
Yeah. So my first question is, what are some therapeutic options available for improving the chances of successful pregnancy in women suffering from RPL?
Yeah, that's what I told you. Since RPL is multifactorial, we have to, first of all, do a battery of tests to find out or to pinpoint what is the cause. If we pinpoint the cause and treat, probably success is going to be ours.
Okay, sure. I think you did talk about much in detail about all the options that are available. So moving ahead, ma'am, my second question is, what are some genetic risk factors for recurrent pregnancy loss? I think this also you've mentioned, but if you want to just brush.
Yeah, advanced maternal age. If the father and mother are carriers of balanced translocations. So whenever you have an early abortion, the system that should be followed is send the abortus for a microarray, rule out any chromosomal abnormalities in the abortus. If you find chromosomal abnormalities in the abortus, then do a parental karyotype, whether any one of them is a carrier of a balanced translocation.
Okay. Our audience has also shared some questions. So my first question from the audience is from Dr. Rajiv Dalu, says, what is the incidence of thyroid disorders among such RPL cases?
Well, the incidence may vary from place to place, depending upon, in India, we have a lot of hypothyroidism, less of hyperthyroidism, but thyroid disorders are seen in a good percentage of patients. In our area, around 5 to 10% patients will have some or the other, most of them would be hypothyroid and a small percentage would be hyperthyroid. And correcting thyroid early in pregnancy really helps to prevent spontaneous abortion.
Okay, sure. I hope that answers the question, Dr. Al. My next question is from Dr. Sita Ramadevi, who says, what is the role of I think LMWH we spoke about in RPL,
low molecular weight heparin.
In RPL with an unidentified cause?
Yeah, unidentified RPL, people have used low molecular weight heparin because ultimately at the placental site there is inflammation, and wherever there is inflammation there is clotting, and these clots need to be lysed if a good communication has to happen between the maternal blood and the tropoplastic villi. The fetus has to get nourished. So low molecular weight heparin has been empirically given for women with recurrent spontaneous abortions. But in APL syndrome, it definitely has a role.
Okay, sure. Moving ahead to my next question. This is from Dr. Anjali Kamath. If you could talk about recurrent chemical pregnancy investigations.
Yeah, actually, chemical pregnancies can be considered as implantation failures also. And there we have to go into all the details of implantation failure problems. That could be the embryo or that could be the decidua itself. And I've told you that there are a lot of factors that can lead to implantation failures. But the known today are the CUR gene inherited by the mother and HLA-C in the embryo. Most of them can land into an implantation failure.
Okay, thank you so much. Moving on to my next question, which is from Dr. Bulus Antoni, who says, is there any role of urologist in this particular case of RBL?
Yes, if the husband's sperm DNA are damaged, we definitely need a urologist to rule out any epididymitis, anything in the presence of a varicocele, a hydrocele. There is a big role of the urologist in treating patients with male factor as a reason of recurrent spontaneous abortions.
Okay, sure. Ma'am, a couple of more questions before we close. So if you could talk in detail about the immunological reasons for recurrent pregnancy loss, and especially because I think the guidelines that are laid down by these bigger groups, they probably miss out on these pointers. So if you could just talk about.
Well, see, the immunological part of recurrent pregnancy loss is still at the research stage. I think we are just blindly trying to find the elephant. Somebody says it's like the tail, somebody says it's like the tusk. But what is known today is definitely the CD56 cells inside the endometrium or in the decidua. These are a little different from the CD56 cells in the maternal blood. And these CD56 cells, these are the natural killer cells. These cells, if their percentage goes high, and the difference between these cells in the blood and in the maternal decidua is that the CD56 in the blood has got CD16 presentation also on it. Whereas in the decidua, it is only CD56, there is no CD16. Presence of CD16 makes these cells very toxic. They release a lot of toxic granules from the cell whenever they meet a foreign antigen. Whereas CD56 only is much milder. Besides that, we have other immune cells in the decidua, like the dendritic cells. The dendritic cells also become tolerogenic during pregnancy. And we have the Th1 and Th2 type of cells, the macrophages. Now, what happens is all of them are modulated by 3 hormones. One is the HCG, human chorionic gonadotrophin. Second is progesterone, which is the most important hormone. But for progesterone to be active, we also need prior estrogen. So when all these are in balance, usually the implantation occurs, and it occurs because of the modulation made by these hormones on the epithelial cells, the decidual stromal cells, and the immune cells, all of them. And human chorionic gonadotrophin not only affects the immunity or changes the immunity to make it, more available for, more acceptable for the blastocysts, but it also causes angiogenesis, increases the vascular permeability in the decidua, helping this foreign graft to grow within the decidua.
Ma'am, also, I think you did mention that there are a lot of controversies around various immunotherapy options that are available. So, what are your views on that? And any takeaway, more message for our audience for watching us live?
Yeah, I feel we need more research. We need more standardization. We need more tests. We as clinicians only see patients, but we do not get accurate test results. Like, is she a hyperimmune rejection of the embryo, or is she a hypoimmune rejection of the embryo? Or exactly what is happening in this woman? We need a battery of tests in order to be able to, get this crosstalk perfect. And in this battery of tests, if supposing they are even going in for IVF, then we want to know the spent culture media, chromosomes, not only the chromosomes, but the embryo itself is also producing many cytokines which help in its implantation. So whether the embryo is producing those cytokines or not. In the recent literature, the embryos produce a lot of lactic acid. And this lactic acid is a very important player in implantation and progress of the pregnancy. So we should know how much lactic acid is present in the spent culture media. That is from the embryo side. And from the maternal endometrial side, we should know that the entire upregulation of all the 238 genes required for production of cytokines during implantation are there, and they are functioning. And that all the hormones, their receptors, everything is available so that this crosstalk can be perfect. As on today, if we see women with recurrent spontaneous abortions, at least as a clinician, what we can do is look at the ultrasound pictures. Does it look genetic or non-genetic? If you see a very large yolk sac, then probably we are dealing with a genetic problem of recurrent implantation failure. But if you see an RP clot, blood behind the placenta, we are probably dealing with an immunological cause of recurrent pregnancy loss, and we should investigate her for immune rejection by doing her CD56, T regulatory cells, CD17, TNF alpha, IL4 levels. That will give us some guideline, and we'll know whether she is in the hyper or hypoimmune state. And we can use her, giving her an idea that these are not standard guidelines, but we can use IVIG, intralipid, or steroids, or TNF alpha inhibitors, or hydroxychloroquine.
Okay, yeah, makes a lot of sense. Ma'am, I have received one more question, and if you don't mind, we can cover those.
Yeah.
So this is from Dr. Rekha Rani, who says, what is the role of GCSF in a pregnancy loss case?
Yes. See, GCSF is actually a stem cell stimulator. It stimulates the bone marrow stem cells. And GCSF is used a lot in regenerative medicine. So whenever there is immune deficiency, like we do not have enough CD56 cells in the endometrium, and the proper, the transforming growth factors and all the factors which allow the embryo to implant are not produced, the embryo will not grow, or it will get lost, or it will be aborted. So to increase the number of these cells, we use GCSF. So in a hypoimmune state, we use GCSF. In some studies, they have used subendometrial GCSF in order to increase the implantation and the pregnancy rate, along with using PRP in hysteroscopy.
Okay. Thank you so much. And there's a message from her as well. Thank you so much, ma'am, for the answer. So I think with this, we can, thank you so much, Dr. Jilla, for being so kind and so patient for all the questions, and always being very, very open and, welcoming on joining us on these sessions on Doplexes. And with this, I think we will close today's session. And dear audience, please feel free to share more questions and any queries if you may have. we would make sure that Dr. Jilla does share all the answers with us. And she's very kind with us in terms of availability. Thank you so much, ma'am, for your kind time
Thank
and
you.
effort in putting together this wonderful lecture for us. And we will be back with soon yet another clinically session exclusively on dog plexus. And until we meet you again, please take care and have a great evening ahead. Thank you so much. Thank you,
Thank
ma'am.
you. Thank you.
Have a good evening, ma'am. Bye bye.
Stop share.